This lectureship was established in 2020 in honor of Dr. Pitt and Betty Pitt to their commitment to quality in HPB surgery. Dr. Pitt is currently at Rutgers Cancer Institute of New Jersey in the Robert Wood Johnson University Hospital as Chief Oncologic Quality Officer. I think all of you should be very familiar with Dr. Pitt's lifelong commitment to quality in the HPB space. I truly do not think that there is anyone in American surgery who has contributed more to quality in HPB. And I'm not just saying that, Henry. Dr. Pitt was extremely instrumental in making NISQIP much more focused on HPB outcomes in improving the quality of care of HPB patients. So I just want to recognize Henry and Betty. So this year we have a real treat. Unfortunately, Dr. Moffett-Bruce could not be with us due to some of the travel restrictions in Canada. Susan is a dear friend and a colleague who I know well from Ohio State. Dr. Moffett-Bruce completed her undergraduate degree at McGill University and her medical school and general surgery residency at Dalhousie University. She spent 3 years at University of Cambridge, England, where she completed her Doctor of Philosophy in Transplant Oncology. She then completed a cardiothoracic surgery fellowship at Stanford University with additional training in thoracic transplantation. Germane to this lecture, she has been trained at Intermountain Health, the Institute for Healthcare Improvement, Harvard School of Public Health. She is also a Six Sigma Black Belt, and she has completed her Master's of Business Operational Excellence as well as an Executive MBA, both at the Fisher College of Business at The Ohio State University. As a practicing thoracic surgeon, Dr. Moffett-Bruce served as the Executive Director of University Hospital at Ohio State Wexner Medical Center and was the inaugural Chief Quality and Patient Safety Officer at our medical center. In this role, Dr. Moffett-Bruce was responsible for data collection, analysis, and process improvement for an academic medical center with 7 hospitals, over 1,300 beds, and over 1,200 physicians. Under her direction and supervision, she led a team of professionals to drive quality improvement across the entire healthcare system. And over the last decade, Dr. Moffett-Bruce has been among the top leaders in quality and patient safety initiatives in the United States and Canada. In January of 2020, we unfortunately saw Dr. Moffett-Bruce depart Ohio State University to take on an amazing leadership opportunity. In January of 2020, Dr. Moffett-Bruce was appointed the Chief Executive Officer of the Royal College of Physicians and Surgeons of Canada. So I could think of no better person, more qualified individual to speak to us today on the topic of quality. So Susan, welcome virtually, and so happy that you're here with us today.
Hello, I'm absolutely delighted to be here today to provide the Betty and Henry Pitt Quality Lecture. The title of my lecture is Leveraging the Learning Healthcare System to Improve Quality Outcomes, and I'm absolutely delighted to be here today. I'm Susan Moffett-Bruce, the CEO of the Royal College of Physicians and Surgeons of Canada, and I'm a professor of surgery here at the University of Ottawa in Canada. I was previously the Chief Quality and Patient Safety Officer and the Executive Director at the Ohio State University Wexner Medical Center. I wish I was there in person with you today, and so I apologize for this video recording. I hope everyone is enjoying the meeting and keeping safe. As I am speaking to you from Ottawa, Canada, I will take a moment to reflect that I am sitting on the unceded and historical territory of the Algonquin Anishinaabe people. I am a settler on these lands, and I take a moment to reflect on those that have gone before. The volume to value care transformation is the paradigm that we find ourselves in now. And this is a change paradigm in the way that many of us will have trained. It is the change in the paradigm of how we've taken care of patients for many years. But over the last decade, the volume to value transition has been a very real one. The volume, the repetitions, the capture in every case, and pay for every case has changed. And now we're in a value-driven healthcare situation. This has been quite prominent in the US and becoming more so in Canada as well. And it's one to continue as we look to quality-driven care. Value itself can be defined as quality over cost. And whilst many of us can measure quality in patient satisfaction, patient-reported outcomes, even mortality, patient safety indicators, the denominator, the cost, is somewhat more complex. And in some instances, it is in the eye of the beholder. But nonetheless, we as surgeons, as care providers, have to understand this value-driven healthcare paradigm that we find ourselves in now. And it's one that going forward is going to hopefully drive better outcomes for our patients. Understanding this shift in volume to value care, I really wanted to study and understand the learning healthcare system. And so over the past decade of my career, I've been very interested in how to not only understand the learning healthcare system, but how to also leverage it. And leveraging the learning healthcare system is very much dependent on quality improvement. If you look at the absolute definition of learning healthcare systems, we know that it has to have leaders that are inherently committed to a culture of continuous improvement. These are leaders that want to learn, that want to improve, and want to engage at a system level. It does involve applying evidence in real time and sometimes changing the way that we care for our patients. It involves employing IT solutions. It involves really leveraging clinicians to improve decision-making. Always in the middle of a learning healthcare system, we must promote the inclusion of patients and all stakeholders and care providers in the solutions, and capturing and analyzing the data so that we can continuously improve is absolutely paramount to the learning healthcare system. I've committed the past decade of my career thus far to understanding and leveraging the learning healthcare system. And in so doing, I have probably written different chapters of my career so that I could truly understand how I could make a difference. The first part of leveraging the learning healthcare system was one around understanding how to engage in quality improvement. Now, I will share today during this lecture that I feel that there are three parts to a learning healthcare system: quality, research, and operation. But for me, and I think for many, leveraging the learning healthcare system starts with understanding quality improvement. I have studied quality improvement for many, many years. I've taken great courses from great leaders in the space of quality and patient safety. And there are many great courses out there, many great resources to improve quality. And through that, I think I've probably distilled my basic approach to continuously improving quality into three steps. The first is that of identifying that there is a problem. And sometimes this is really quite difficult because this can involve accepting that the outcome is not what we had intended. And that grief can be very real. And we have to be brave enough in some instances to say so. Transparency is absolutely key to identifying that there's a problem. And it is one that starts the process of improvement. Step two is around coming to a consensus as to the solution. Now, this can take some time. And it's really important to engage key stakeholders, the voice of the patient, and the healthcare providers. The time is so worth it to gain a consensus as to the solution. The more time you spend, often the better solution. And then thirdly, always measuring the impact on the solution. The solution cannot be measured unless we truly dedicate resources, dedicate commitment to measuring and sharing. And sometimes the outcomes aren't exactly as we had intended, but we still must measure so that we can continue the cycle of continuous improvement. So 3 steps to improving quality: identifying there's a problem, come to a consensus as to the solution, and measure, measure, measure. At OSU, the path that I followed to improving quality, first for my own practice, then my division, and then the healthcare system as a whole, was really the beginning of, was really started by using the checklist. When the checklist at OSU was first introduced, it was just after Atul Gawande had published his paper in the New England Journal of Medicine that clearly showed that checklists improved outcomes. Since the introduction of the checklist, the number of checklists have blossomed at OSU, and it became a very pivotal part of the patient safety story. But it was more than just a checklist. The checklist allowed us to start a cultural transformation to really engaging providers and patients in quality improvement. Now, I can assure you, the first time that we rolled out the checklist without going through those first steps, particularly gaining consensus through stakeholders, they came down promptly. But after truly understanding how the checklist was going to be used, engaging stakeholders, and then measuring its success, the checklist continues to be a pivotal part of the patient safety story. And I think it's one that truly started the journey. And as I said, the cultural transformation around quality improvement being innate to all that we do. The way that we were able to introduce the checklist such that it began a cultural transformation to improving outcomes, to improving quality, and leveraging the healthcare system as a learning healthcare system was by introducing team training. We called this crew resource management at The Ohio State University, and it was embraced because not only did our frontline providers understand the importance of it, but our leaders, our chairs, Dr. Pollack, Dr. Ellison prior to that, our dean, our CEO, they all, not only do they take the training, but they engaged in it. They were present for when our team members were undergoing the training. And this team training became a pivotal and required part of resident and attending provider and other providers onboarding at the medical center. It initially was a 4-hour required training in teams of between 15 and 20 people. And then it became much more distilled and streamlined. But still, it became pivotal. CRM, or crew resource management, was really code for quality improvement throughout the medical center. And it was great teamwork that I truly think started and continues to engage and embrace quality improvement in all we do. And part of it was training our teams, our providers, our surgeons, how to do quality improvement. So a little bit of a different type of operating room here, whereby we were now practicing how to do quality improvement. We are now showing each other how to do fishbone exercise, how to do root cause analysis, how to run simulations so we could improve outcomes. And over the years at OSU, we trained dozens of physicians, nurses, and other healthcare providers in quality improvement so that not only could everybody understand the language of quality improvement, but that everybody had the tools to help engage in it. And then it became a train the trainer, even for simple tests of change. And it became very much not only innate to our culture at the medical center, but absolutely important to continue our commitment to quality improvement and continuous improvement throughout the care continuum. So a little bit of a different type of operating room here for me, but was one that I think I probably influenced more in the outcomes of patients. And as I said earlier, we had to identify that we could do better. We had to engage stakeholders in the improvement. And then ultimately we had to measure. And as we rolled out crew resource management, team training, we measured the pre and post training success. Here you can see just an example of our surveys that we used before we did the training and after, so that we could get a sense from those that were taking care of patients as to whether or not we were actually making a difference. And we were, but not in every area. And when there were areas that we weren't making improvements, we were able to go back to either do the training again or do it differently, so that we could truly engage teams in improving the way that they were able to engage in quality improvement. In some instances, we were actually even able to measure the improvements relative to the cost of implementing a quality improvement program relative to outcomes. And again, the measurement strategy, depending on the audience that you're speaking to, is very important to set the platform, to set the understanding that you can make a difference throughout the healthcare system if you measure and then have a control phase and sustainability plan as to quality improvement. But suffice it to say, not always is every quality improvement project successful. And sometimes you have to think of it in a different frame and then through a different lens. We had been very, very committed at The Ohio State University to falls prevention. And so we had rolled out a really important and a very innovative falls reduction program. Unfortunately, it was not sufficient. And after a patient suffered a fall, we worked with a family for many, many months on a different way of preventing falls, and hence the wheel was created. This is Roger's wheel, and Roger's family worked with us for many months so that we could look at reducing falls in a different way, using a very bright and colorful template and tool that not only could our care providers understand, but our patients and their families could understand as well. Of course, we measured the success, we measured the challenges, and we published it so that we could disseminate the way in which we had approached falls reduction with a family member. And this was really pivotal as well to our cultural transformation, when we were able to transparently look at improvements in something as straightforward as fall prevention and think about it again through the lens of the patient. And so you might ask, why? Why do we always have to think about continuous improvement? Why do we always have to think about different ways in doing things? I think first and foremost, most of us would say because it's the right thing to do. Because if I were the patient, I would want the very best care. But there's also an external pressure, and that public reporting continues to evolve. Public reporting, your outcomes at the hospital level, at the system level, and at the surgeon level and physician level will continue to evolve. In some instances, there are 700 top 100 hospitals, depending on what measurement system you look at. But these measurement systems are not going to go away. And they have been fairly popular and fairly developed in the US, and now they're starting to come into Canada. And this is the reality that I think all care providers are going to be facing going forward. In some ways, it does help to set the burning platform. In others, it makes us even more poised to engage and be at the table when metrics of quality improvement are being decided upon and when reporting and how it's going to be shared is being decided upon. We have to be at the table, and quality improvement and understanding how to engage in it will be paramount to being part of these reporting mechanisms. So for many years, I was very engaged in quality improvement. I had great teams. I've always been so grateful to the providers and the administration to really help us leverage and elevate quality improvement so that we could bring the best out of the healthcare system to improve the patient experience. And as we were getting our processes really fine-tuned, as we were really engaging providers so that quality improvement became innate to everything that we did, we started to think about research. How could we disseminate? How could we leverage all of these great improvements to make even more impact? And so the second chapter of the learning healthcare system is really around research. And it was one that perhaps we hadn't expected, but there was a call in early 2015 for a AHRQ grant. And in the course of probably 6 weeks, we were able to pull together team members to submit an application that just basically looked at all the programs that we had already had in place. And here you can see the submission, because in 2015, it was a paper submission, and the team came together to leverage the work that we had already done in quality improvement to now look at how we could look at it through a research lens. And hence, the Institute for the Design of Environmental Line for Patient Safety was created, Ideas for PS. And this was a joint effort between myself as a clinician and a chief quality officer and great scientists, Dr. Anne McInerney and Tim Huerta, that we were able to really pull together teams that had not been pulled together previously. And it was such an opportunity to really bring together the learning healthcare system in a way that we hadn't imagined possible at that point. We were one of 12 institutions that were given these 5-year grants. There were 2 calls for them, and we were able to be in on the second call. And so we were with peers that I'm so grateful to have been in that group. The University of Texas, Johns Hopkins, Stanford, and together we had these patient safety learning laboratories that went on for 5+ years. And really, I think they were able to start a culture of continuous improvement, quality improvement, and leveraging research to truly disseminate and become an implementation science laboratory. And so we were able to pull together through lots of conversations, relationships, leadership, not only the what you would call traditional researchers, but we were able to bring together human factors and engineers, health services researchers who were fantastic with what they did, and clinical researchers. And between us, and there were approximately 40 individuals that were participating in the Ideas for Patient Safety laboratory, we were able to truly leverage much of what we had been doing already to now bring together a research program. The Institute for the Design of Environments Aligned for Patient Safety in this research paradigm was really one around how to use information, how to use communication, and the ways in which we saw flows of information to improve our environment. And we had 3 basic programs within this patient safety laboratory. The first was looking at the information that went from the patient to a detection device to an alarm. And we were really focused on how clinicians were able to care for patients despite having so much noise in the space of alarms and telemetry. The second was using information that you could glean out of the EMR and how we could use surveillance information, surveillance data for infections to prevent and recognize real-time infections that may be occurring. And lastly, we wanted to use the premise of crew resource management, our team training communication mechanisms, to understand how we could better engage with patients at the bedside and beyond through the electronic medical record, using the same principles that we had used in our team training early on in our cultural transformation. And so these 3 projects were the foundation of the laboratory, and they are ones that continued on for many, many years. For the first project, our reality was that we had many, many patients that were being monitored in many ways. We did some very initial measurements, and we could see that despite having tens of thousands of alarms by week, 90% of them were not clinically relevant. And so you can imagine the amount of noise that our nurses, our providers were experiencing. So we engaged with our nurses, our physicians, our patients, and we were able to actually leverage our human factors experts to really understand who needed to be monitored, how they need to be monitored, and what were the sounds that were most pertinent to that monitoring. In doing that, and you can see some team members here in our workshops, we were able to not only reduce the number of patients being monitored, but we were also able to improve the experience of the patient and the providers at the bedside who were listening to these alarms. A very practical project, and one that actually improved outcomes because patients were able to get a hospital bed faster and often be discharged sooner because they were no longer monitored. The second project was around really leveraging the electronic medical record. We have all this information in electronic medical records, and we took about 5 years of data, and we were able to create an algorithm that will allow us to predict potentially where infections might occur, depending on variables, including white cell count, temperature, some demographic information, and using and leveraging our geography experts, we were actually able to do some digital hotspot so that we could actually see not only where infections might occur, but which patients should be placed near which other patients. So for instance, if you had predicted a patient to have an infectious environment in exam room 12 seen in red, you wouldn't want to put an immunocompromised patient in that room. And it became really a nice collaboration between our geography department, our infection preventionists, as well as our nursing and transfer center teams, so that we could truly leverage every bed for every patient and improve throughput. And then the third project was really trying to figure out how you take information that looks like this and actually improve the patient experience. And so we were able to do that with our informaticians, with our nurses, with our patients, and figure out how we could actually, at the bedside, provide to patients the information they needed to improve their experience, improve patient safety, and improve the experience for the nurses. Because the patients now had so much information, and the MyChart bedside became one of our tools that we were able to use not only in our research, but also practically in the patient care. And out of that, we actually were able to develop a really nice relationship between our research teams and our nurses, whereby our research teams were able to go to the floor and not only study some of the effects of having the MyChart bedside and these tools for patients, but they were actually also able to help the nurses because they were able to train some of the patients on MyChart using the tablets that then the nurses didn't have to focus on. And the technology navigators, as they became known as, became an instrumental part of the staff and the team, which became a really nice way of integrating research with clinical care. And so those 3 projects over more than 5 years were able to not only leverage quality improvement and a lot of the work that we had done prior to receiving the grant and becoming the patient safety laboratory, but we were also able to leverage for scholarly activity. We had many peer review articles, many presentations, and we still have ongoing work in all three of those projects. And I'm really pleased that part of this work became the beginning of Catalyst, which is the Center for the Advancement of Team Science, Analytics, and System Thinking, which at OSU is now led by Dr. Ann McInerney and Tim Huerta, and truly is a very innovative, forward-looking health services research laboratory. And so 2 pieces of the puzzle, 2 chapters of my history in quality improvement for leveraging the learning healthcare system. But then the third became, how do you leverage this so that every day the operations may be impacted by the quality improvement, the research thereafter, and truly integrate it and leverage the system in which we're doing all of this great work. And for me, that was really very important so that we could become not only important relative to our quality improvement, but that it became so innate that became incorporated into daily operations. And so we started to use some of the skills that we had learned in our quality improvement strategies, as well as our research. And you can see here a colleague using virtual reality to actually start looking at and how to build the new hospital that is going up at The Ohio State University. We were able to use other techniques like simple whiteboards to engage people in continuous improvement for the building of the new hospital. Very operational, but we used some of the skills and tactics and techniques that we had used in quality and research so to inform the building of it. We made up mock-ups, which we had learned this in our workshops for the alarms, that really having in situ laboratories, in situ places for people to go and test out things really were foundational and fundamental to making decisions. And these different techniques, which we had used in quality, which we had used in research, became foundational to the building of the new hospital. And so through this process, we were able to hopefully influence the hospital that someday soon will look like this and will have, perhaps as part of its basic makeup, quality improvement and research that have influenced it. And we were also able to do some really cool things relative to we were able to design an offsite CSS, a central sterile supply, again, based on our quality improvement work and research. And you can see here the staff that had a meal. And if you'll notice, this staff that clean the instruments, prepare instruments for the OR, usually work underground. And this building is one that is above, that really looks to elevate the experience of team members. And I can assure you that by doing that is going to improve the outcomes of our patients, because these great team members influence the outcomes of every surgical and procedural patient at OSU. And truly, this was one of the greatest things that I hope I influenced. And I'm truly grateful to Dr. Pollock for his continued support in this project. And so I think I've shown you that leveraging the learning healthcare system is really all about quality improvement. It's foundational, it's fundamental, and you can leverage a learning healthcare system and always improve quality. But I think what I have learned, and maybe it's taken me some time, is that part of improving quality is understanding truly all of the indicators that must be influenced. And I think one of the missing quality indicators, and probably why we have such an issue now, is physician wellness. And so I think that it is important to talk about this as part of leveraging the learning healthcare system, because without physicians and all providers being well, we will not be able to advance learning healthcare systems so to improve outcomes. And I would say that similar to improving quality, there are 3 pieces that I have learned are important to physician and provider wellness. And I just want to share a little bit about each of them now. The true north, resilience, and a little bit of grit. So what is a true north? The true north, is really defines what you want to get out of the system. It's why we get up in the morning and why we take care of patients. It's really, I suspect, for all of us, is to provide high quality health care. And I think throughout the process of either quality improvement, research, operational improvements, if we always have the true north at the very core of what we're doing, we can stay on course. I think it helps us understand how to avoid diverting from our path, but I also think it allows us to give us some hope as to how we're going to go forward. And so I think the concept of the true north is one that's worthy for all providers to understand, so that they can understand how to have a shared vision with colleagues, how to understand why they're doing something, and truly how they might understand where the failures occurred. Resilience. We talk about this a lot, and I think we can never talk about it too much. But I would share with you that there has been a paper written just over the past year by Mike Mattis, who is a cardiothoracic surgeon, and he speaks about this resilience bank account. This bank account is one that we can all influence, and by every time having a good sleep or going for a run, we deposit into our bank account. That by being grateful and having self-compassion and being connected and kind to others, we deposit into our bank account. And I think it's a really nice concept for us that as surgeons often need really concrete examples of how to become resilient and actually how to do it. And I would, if you had the time, ask you to review this paper. It's well worth the time. And then thirdly, grit. And grit is really about perseverance. It's about having that purpose and conviction and understanding your true north, a little bit of hope, and quite frankly, just getting up every time you fall down. And so these three parts of wellness are three that I have very much thought about over particularly the last 18 months as we've come through this pandemic, because I think these three parts influence how we can be part of continuous improvement, how we can be part of a learning healthcare system, and how we can advance and improve outcomes for patients through our own wellness, through our own understanding, and through our own conviction to going forward. And so I've often thought about how to pull it all together. And this is my resilience framework, whereby I think we, as surgeons, healthcare providers, administrators, if we really focus on the true north of improving outcomes, the true north of leveraging the healthcare system, we're going to have to be resilient. And resilience is something that we need to embrace, that team members need to mutually embrace. But sometimes resilience is not enough. And every now and again, you're going to need a little bit of grit to get over the hurdles that are thrown our way. And so maybe in summary, leveraging the learning healthcare system is completely dependent on quality improvement. The quality improvement means that we collectively have to take care of ourselves so that we can make change. And there are many lessons learned along the way. I think those that resonate with me most, first and foremost, is being respectful of the past, but very curious for the future, and now more than ever. I think we can never be satisfied with status quo, but I think that can be exhausting. And so we have to be kind to ourselves, to others, and always try to be very conscious of taking care of ourselves. Quality improvement is not just quality improvement, it's cultural change. And I would suggest, and I have done this, is surround yourself with really smart people and let them shine. Because this is a team sport. And the bigger the team, the more the impact. I had an outstanding team. who were able to help leverage the learning healthcare system. And I will be forever grateful for that experience. And now I carry it forward into the work I do now here at the Royal College. But this great team was paramount to any success I've ever had thus far. And for that, I will be forever grateful. And so I think in reflection and in summary, leveraging the learning healthcare system is something we can all do. It's very dependent on quality improvement. It's very dependent on our own improvement and our own wellness. And I think it's something that we can use going forward to understand the volume to value transformation that is very much paramount to how we're going to care for patients and improve outcomes along the entire care continuum, regardless of what life might throw us. Because there's always going to be a curve in the road, always going to have to go around the next bend. And I think through truly embracing quality improvement, we will all be up to the challenge. I thank you.
So I know Dr. Moffett-Bruce is live on Zoom, and so you can hear us. So I just want to thank you, Susan, for a really wonderful Betty and Henry Pitt quality oration. The work that you have done in the quality space is truly amazing, both with regards to research, implementation, and your leadership, and the impact that you've had on one healthcare system here in the United States during your time at Ohio State. Will be a legacy, and we're even looking forward more to the impact that you'll have in your executive leadership role with the Royal College of Surgeons. I also just want to again recognize Dr. Pitt and Betty Pitt for your unwavering support of this lectureship and your commitment to quality in HPB surgery. So thank you very, very much.